Hello everyone. So for Fellows Conference this week, we're going to be talking about a couple different things with regard to the liver. Two actually pretty broad topics, but hopefully with this video we'll be able to touch on some important aspects of hepatocellular carcinoma. So the objectives of the talk will include obviously some background, and we'll talk a little bit about workup, imaging, and some other aspects of that. And then finally, evaluation for surgery, which is probably the most important for us, obviously, and how that has to do with ascertainment of the underlying liver function for a patient, as well as determination of the functional liver remnant for patients who undergo resection. We'll talk on about resection versus transplantation and some data behind that. And then finally some local, regional, and systemic therapies. Although there's not a lot to talk about for that for us surgeons, and actually that could be its own talk in itself in regard to local regional therapies for liver tumors. So without further ado, hepatocellular carcinoma is currently the 5th most common malignancy in men, 9th most common in women, making it the 6th most common malignancy in the world. And its incidence is actually rising, and it's thought to be due in part to the increasing prevalence of the viral hepatitis in the world, including hepatitis C and hepatitis B. Risk factors for hepatocellular carcinoma include, as I said, HBV and CV, alcoholic-induced cirrhosis, and quite frankly any cirrhosis or underlying inflammation within the liver parenchyma, hemochromatosis, Wilson's disease, and alpha-1 antitrypsin deficiency. And seemingly underreported at this point in time, but probably more in the future, we'll hear more and more about the increasing evidence for association with non-alcoholic steatohepatitis, which can lead to cirrhosis, as you know, which is obviously prevalent in Western countries. Histology for hepatocellular carcinoma, interestingly, doesn't necessarily guide treatment strategies, except for fibrolamellar carcinoma. This is found in younger patients without cirrhosis and actually carries a better prognosis than standard hepatocellular carcinoma, and actually can be cured by resection. HCC frequently extends locally in an extrahepatic fashion to the diaphragm, into the porta hepatis, to the abdominal side wall, etc. And metastatic spread of HCC is most often to the lungs, the bone, adrenal glands, and the brain. Fibrolamellar carcinoma has previously been thought to be a variant of hepatocellular carcinoma, and it is less common than conventional HCC. It occurs in young adults, as I said previously, as well as adolescents more frequently than older adults. And typically this is in patients without chronic liver disease or any known risk factors for HCC. The most important, it says risk factor on the screen. Basically the best thing to think about is the most important factor in the care for these patients is the ability to undergo surgical resection, and the inability to undergo surgical resection is the biggest risk factor for death. Surgical resection of fibrolamellar carcinoma results in a 5-year overall survival between 30 and 76%. More patients with fibrolamellar carcinoma are candidates for resection as compared to conventional hepatocellular carcinoma. And this is likely due to the fact that these patients don't typically have underlying liver dysfunction as compared to conventional HCC. Recurrence rates for this disease are high, in some reports as high as 100%, but patients can typically undergo repeated resection, and this does improve overall survival. Interestingly, with this fibrolamellar carcinoma, lymph node metastases are common. Fibrolamellar carcinoma was previously thought to be an indolent tumor with a better prognosis compared to HCC, and this was thought of because of their younger age and their absence of cirrhosis, and they have shared AJCC staging with hepatocellular carcinoma. Quick to point out that nodal metastases in this disease constitute stage 4 disease. A study by Dr. Chun and colleagues here at MD Anderson in 2016 tried to sort this out for patients with fibrolamellar carcinoma compared to conventional HCC. They compared outcomes in 65 patients with fibrolamellar carcinoma as compared to 158 non-cirrhotic HCC patients, so kind of unconventional HCC. So trying to take the underlying liver parenchyma dysfunction out of the picture and compare the two tumors. They found a predominance of stage 4 patients in fibrolamellar carcinoma patients, 46% in this cohort, versus 42% of the 158 patients were actually stage 1. The stage 4 fibrolamellar carcinoma patients had isolated nodal metastases in 81% of patients, and this didn't actually affect overall survival or recurrence-free survival. Overall survival in these patients was actually only affected by the number of tumors and the presence of vascular invasion. Fibrolamellar carcinoma recurrence occurred in 86% of these patients, but almost half of them were able to undergo repeated resection. And the only prognostic factor for recurrence in these patients was actually vascular invasion. So, in summary, the authors concluded that when compared to non-cirrhotic hepatocellular carcinoma patients, patients with fibrolamellar carcinoma weren't actually adequately stratified by AJCC staging due to the fact that almost all these patients had nodal metastases, but those nodal metastases did not affect survival. So in effect, that AJCC staging should predict survival. The nodal metastases for this variant of the disease did not predict survival. Therefore, they think that, and it probably makes sense, that the lymph node metastases for patients with fibrolamellar carcinoma should be considered regional disease as compared to more of a systemic stage 4 disease pattern for conventional hepatocellular carcinoma. So you've got a patient who has underlying liver dysfunction consistent with cirrhosis, and these patients typically undergo screening for hepatocellular carcinoma because obviously they're at high risk. This typically occurs every 6 months with an abdominal ultrasound because it's cheap and an AFP screen. And let's say you have a patient who comes in and gets an ultrasound and has a liver mass found on ultrasound. Typically then the decision tree is divided based on the size of the mass found, and it has to do with whether it's under 1 centimeter, between 1 and 2 centimeters, or over 2 centimeters. And quite frankly, it really just matters if it's under 1 centimeter or over 1 centimeter. If it's under 1 centimeter, then typically we can repeat imaging and continuous surveillance every 3 to 4 months and to see if it grows or not. If it grows, then it's obviously something that's concerning for neoplasm, and it says to treat as HCC. If it's over 1 centimeter, then we have to decide whether it looks like HCC, and you should proceed to another type of imaging, whether it's a CT scan or an MRI. And based on that, as we'll talk a little bit on the next couple slides, as well as next week, if it has imaging characteristics that are typical for hepatocellular carcinoma, then we can treat a patient as having HCC. If it's atypical, then it is not out of bounds to biopsy the mass. AFP, how that comes into the equation is whether or not it's above or over 200 when the mass is over 2 centimeters. So an AFP over 200 and having imaging characteristics on axial imaging such as CT or MRI, very characteristic of HCC, we can be pretty comfortable that this patient has HCC. And these imaging characteristics that we talked about are having arterial enhancement on an arterial phase, with washout on more delayed phases such as the portal venous phase. Most of these patients, as I said, can be diagnosed without having a tissue biopsy. And as we know, there are risks of having a biopsy, including bleeding and tumor seeding, although 0.2% seems to be a little bit high. Seems to, we do biopsies, and the risk is not as often as has been reported with newer, more conventional biopsy techniques. So an AFP is typically increased in up to 50 to 90% of patients with hepatocellular carcinoma. However, it's still not sensitive or specific on its own. And as I said, an AFP of over 200, along with characteristic imaging findings for a patient with a liver mass, is nearly 100% sensitive. Again, an ultrasound is an inexpensive screening tool, but it has a low sensitivity and specificity. You can have false negatives up to 50% for patients. Cross-sectional imaging, such as CT scan, are the imaging modalities of choice. And a CT scan is typically performed with 4 phases: a pre-contrast phase, an early vascular phase, which includes which basically is an arterial phase, followed by a portal phase, and then finally a delayed phase. Liver tumors that have an arterial phase enhancement are typically thought of as being associated with hepatocellular carcinoma, hepatic adenomas, and neuroendocrine tumors. Portal phase enhancement is typically seen in hypovascular tumors such as colorectal liver metastases or cholangiocarcinoma. Hepatocellular carcinoma typically shows washout on delayed phases and does not retain contrast. If we're uncertain about anything in a patient who's at risk for having a malignancy, a biopsy is recommended. A word about LIRADS. This is a new thing that has been integrated more and more since it was first um, uh, described in 2011. I will say that personally I have not seen too much of this affect our surgical management of patients with hepatocellular carcinoma, but it can be thought of as being very similar to BIRADS for patients with breast cancer. And this is a way of standardizing our cross-sectional imaging findings for patients at risk for having hepatocellular carcinoma based on their imaging characteristics, and then give the patient a risk, in effect, basically how confident we are in diagnosis of a liver tumor being hepatocellular carcinoma. So you start with a patient having liver tumor without pathologic proof, so basically not having a biopsy of this mass, and a patient who has a high risk for hepatocellular carcinoma. And then you follow along the decision tree. Looking down below, the first thing to look at is whether they have this arterial phase hyperenhancement that we talked about. And it's either a yes or no. And the yes has to be non-rim. And I think what that means is essentially, is it a hemangioma or not? Does it have the centripetal arterial phase enhancement that's seen with hemangioma? No, then that's non-rim. And then the size matters. So if it's under or over 2 centimeters versus over that. And then there's some additional features that can assign some points, such as having an enhancing capsule, having washout, and then or any growth. And this basically allows radiologists to define what their confidence is in saying a liver tumor is hepatocellular carcinoma. This is all I'm going to say about this because, again, this is relatively new, and I don't think that it's in our daily management for patients yet at this point in time. So yes, I know this is the 7th HACC, but I know that everyone knows we're now on the 8th edition, but I wanted to highlight some things about this that are important. Previously, when we looked at TNM staging for patients with liver cancer, the T stages was as is shown here. So a T1 was a solitary tumor without vascular invasion. So any solitary tumor, right? Without vascular invasion. That could be a tumor I'm 6'5", so the tumor could have been 6'4" and had not had vascular invasion and been T1. T2 tumors were solitary tumor that had vascular invasion, or there are multiple tumors and none of them are over 5 centimeters. T3 was multiple tumors over 5 centimeters, and then T3, T4 getting to be really bad tumors with extension, etc., etc. This is important because this has changed. This was changed because of this paper from Dr. Vote and team, essentially saying that prior AJCC staging did not accurately stratify patients who had solitary tumors with respect to size and the impact of microvascular invasion on outcomes. Previously reported data actually showed excellent outcomes for patients who had solitary tumors up to 2 centimeters in size. And these outcomes, the size cutoff essentially of 2 centimeters was adopted in the more recent editions of the Liver Cancer Study Group of Japan classification, as well as the Barcelona Clinic Liver Cancer Staging System. This paper looked at over 11,000 patients from 6 international centers and performed an analysis based on tumors, whether they were smaller or larger than 2 centimeters. In effect, they're trying to show data to incorporate this size cutoff into AJCC staging. So basically, bottom line is they saw that early stage tumors were better stratified by the LCSGJ and the BCLC staging systems as compared to the AJCC staging 7th edition. So AJCC, what we use is here on A, whereas here in B and C, you can see the Japanese liver cancer staging system, which has a more refined survival analysis for stage 1, 2, and 3 as compared to BCLC. And what they found looking at these patients is that long-term survival was not influenced by microvascular invasion for patients who had a hepatocellular carcinoma that was under 2 centimeters. So in A, you can see that patients who had a tumor that was 0 to 2 centimeters, whether or not they had microvascular invasion, it did not matter. Their survival is exactly the same. But what they saw is that for tumors that were over 2 centimeters, whether or not they had microvascular invasion actually really mattered. All the other things that matter is whether AFP was elevated or whether they had a higher grade. But bottom line is, if you look at B, if they have microvascular invasion in yellow, or patients who did not have microvascular invasion, they actually have a better prognostication based on this size and characteristic. So this figure is a little bit busy, but I'll explain it and it'll become clear what Dr. Vote and his team were trying to say. So looking at figure A here, they've discriminated survival for patients with HCC in having a tumor that is under 2 centimeters, so 2 centimeters or under, as compared to patients who had a tumor over 2 centimeters without microvascular invasion in yellow, or patients who had a tumor over 2 centimeters that did have microvascular invasion. Now recall from the prior slides that patients who had a 2 centimeter tumor or under, it didn't matter whether they had microvascular invasion or not. So that's why they're combined in one group here. So more refined prognostication. Moving on to B, now we've superimposed more patient stratifications here. So again, a solitary tumor under 2 centimeters, that's in orange, okay? And then outcomes for patients who had a tumor over 2 centimeters but did not have microvascular invasion. So you see a separation between purple and orange. Now, take a look at this. This is important. Patients who had a solitary tumor over 2 centimeters with microvascular invasion as compared to having multiple tumors under 5 centimeters. Their survival is exactly the same. And then lastly, having multiple tumors over 5 centimeters here in green had the worst prognosis. So moving forward, they propose that we should have as compared to what was prior AJCC 7th edition staging. In new staging going forward, it proposes a new T1A, which is a solitary tumor under 2 centimeters in blue. Their new T1B is this yellow curve, and that corresponds to a solitary tumor over 2 centimeters without microvascular invasion. Sorry, that was T1B. And then new T2 combines these overlapping curves, which is having a solitary tumor over 2 centimeters with microvascular invasion, as well as patients who have multiple tumors that are under 5 centimeters here in green. And then lastly, multiple tumors over 5 centimeters is in orange. And so this is what they propose here in their final table of their paper, which compares the AJCC 7th edition we talked about earlier as compared to their proposed new classification for T1A and T1B, a more refined T1, as well as a new T2 staging system here. And because of these survival curves that were presented in this paper, the AJCC's 8th edition T-stage was broken down as illustrated above. And here is the new AJCC 8th edition staging criteria. N and M have not changed. The T stage now has 2 subcategories, as I said, T1A and T1B. The N stage going forward is N0, N1, depending on whether there's regional nodes, and N1 denotes stage 4A disease. Stage 4B disease are patients who have distant metastases. So other forms of staging for HCC include the Barcelona Clinic liver cancer staging system. And bottom line is the difference is that this staging system incorporates individual tumor biology with individual liver function and their performance status, as well as tumor size. So essentially, early stage BCLC tumors are small, under 5 centimeters. Patients have an excellent performance status, and they have evidence of normal underlying liver function or having some portal hypertension and a varying degree of elevated bilirubin. And then bottom line is, as you get from stage A to stage B and then C, which is intermediate and advanced, patients either have a worsening performance status or they have large, bad, bulky tumors with vascular invasion or evidence of cirrhosis, not just portal hypertension, actual cirrhosis. And management as proposed according to this staging system goes along the spectrum from resection to best supportive care based on whether they have individual poor tumor biology, liver function, or performance status. And I won't talk about too much more about this because this isn't typically how we manage patients in the United States. Underlying liver parenchyma is important. It hasn't been incorporated into AJCC staging as of yet, but it does say that this should be noted, and obviously underlying fibrosis of the liver parenchyma is basically a measure of cirrhosis and underlying liver dysfunction, which is something that we take into account when trying to decide how to treat patients. But there is an actual fibrosis score, and it's typically denoted with an F. And this does actually have significant prognostic value for overall survival for patients undergoing care with HCC. Severe fibrosis has a negative impact on overall survival as expected. Stage 1 disease patients, for example, with HCC have a 5-year overall survival of 64% if they have a score of F0 for fibrosis, but that goes down to 49% if they have F1. Stage 2 and 3 disease is 46% and 17% at 5-year overall survival for patients with F0. And this goes down to 30% and 9%, under 10% 5-year overall survival for patients who have F1. So fibrosis really does impact survival. You can imagine how this dictates surgical management for patients with stage 2 and 3 disease, and this is only based on tumor size and microvascular invasion. They can have a solitary tumor that's totally resectable, but you can tell them based on the underlying fibrosis that they have a very poor 5-year survival. So, how do you select patients for surgery? And we haven't talked yet what this surgery is, but typically we want to look at a background of cirrhosis, and we have to assess their underlying liver uh, function. And this is a table here. I should have put a title here, but this is a table of the Child-Pugh, sometimes called the Child-Pugh-Turcotte um, scale for measuring cirrhosis for patients, and it's based on a number of factors, as you can see there, whether they've had encephalopathy in the past, evidence of ascites, elevated bilirubin, depressed albumin, and prothrombin time. And they're based into child A, B, and C based on the total number of points that are assigned according to that table there. Patients who have child A typically can tolerate hepatic resection, whether it's minor or major. Child B and C, though, sometimes we have to definitely try to risk stratify these patients, as child B can only tolerate minor resections classically, and child C cirrhotics typically don't tolerate anesthesia very well, won't tolerate an incision or really many surgeries at all, and they should be considered for transplant or local therapies. Anatomically resectable HCCs who don't have extrahepatic spread, we should consider other clinical parameters, degree of portal hypertension, as well as having platelets over 100,000 and absence of varices. And these are the typical characteristics for patients who we would consider for resection MD Anderson. The next step is to determine the functional liver remnant volume. And this has been the subject of prior talks that we can find on the K drive. Notice the small s there. For those of you who haven't done liver rotation as of yet, functional liver remnant with a small s denotes a standardized FLR, and that's standardized to patient size. And if you go back through the prior talks, they'll go through that for you. I just want to talk a little bit about something that we don't do here in the US, but a lot of the world does, and that's testing the underlying liver function for cirrhotic patients using the ICG clearance test. And this has been widely popularized by data from Dr. Mikuchi at the University of Tokyo. And talk about an amazing title for a publication with your name on it: 1,056 hepatectomies without mortality in 8 years. That's pretty ridiculous. And in this paper, they basically set what is the safe limit of hepatectomy for patients with underlying liver dysfunction. And they say that that is determined by, number one, the presence or absence of ascites; two, the total bilirubin. That V in front of total is a total typo, sorry. And number three, the ICG green retention rate at 15 minutes. And as you'll see here in a second, in patients who do not have ascites and have a normal bilirubin, really the extent of surgery that can be performed for patients is really based upon their ICG green retention rate at 15 minutes. Bottom line is, and I could talk forever, I think in a 1 hour presentation we could have an entire presentation on ICG green retention. Bottom line is indocyanine green is a compound that is taken up by the liver and secreted into bile by hepatocytes, and it does not escape the liver. It is completely removed by the liver. So basically, as you can imagine, its clearance into bile is based upon the ability of the individual hepatocytes to clear it, as well as blood flow. So if there is portal hypertension, number one, and then hepatocyte dysfunction, you can imagine the green gets retained within the liver because it can't pass through. Make sense? So its retention rate of 15 minutes has been standardized in a fashion that allows for a determination of underlying liver dysfunction. So as proposed in this paper here, this is how Dr. Makuchi and colleagues stratify their patients for extent of resection available for patients with underlying liver dysfunction. So they start with ascites, yes, no. If there's none or their ascites is controlled, they then go to the next step, which is to ascertain the patient's bilirubin level. And as you can see there, if it's normal, you then do an ICG retention rate. So if it's elevated, then they have an array of ways to determine whether they undergo limited resection or enucleation or no hepatectomy whatsoever based on their bilirubin. But if bilirubin is normal, they then perform this ICG retention in 15 minutes. If that's normal, they can undergo a major resection. If the retention rate is between 10 and 19%, they can undergo a left hepatectomy or a right sector, so right posterior or right perimedium. And then getting along the spectrum of increasing liver dysfunction, and that corresponds to increased retention of green. They then can go from anywhere between segmentectomy to only enucleation. As you can imagine, then much higher that you would expect they'd have an elevated bilirubin or uncontrolled ascites and wouldn't be eligible for hepatectomy. So surgical resection or liver transplant are the standard surgical treatments for hepatocellular carcinoma. And we favor resection when possible because of a decreased morbidity, obviously, compared to liver transplant. Also, liver transplant is, organs for liver transplant are scarce, as we all know. Sometimes patients have inadequate functional liver remnant prior to a planned major hepatectomy for HCC, and PVE, when indicated, is a useful adjunct. Here's a paper from Dr. Vautier and colleagues describing this because PVE has been performed to minimize risk for patients with inadequate FLR for other pathologies in the liver, but its effects on tumor growth weren't really well defined, and there was concerns that tumors could progress following PVE in these patients. So they looked at patients who underwent PVE for inadequate FLR prior to a planned major resection for HCC, and found that patients who underwent PVE had equivalent overall survival and disease-free survival as compared to patients who did not undergo PVE. So it's safe. And in regards to safety, patients who underwent a PVE experienced less major complications as compared to patients who did not. And interestingly, there was 0%, 0 deaths in patients who underwent a PVE prior to major hepatectomy, as compared to 18% perioperative deaths in patients who underwent surgery without PVE. So in fact, it's actually very protective. When considering a patient for surgical resection, the really only absolute contraindication is the presence of extrahepatic metastatic disease, and this is even arguable in some cases, but overall that's the only major contraindication. And then also, obviously, we have to ascertain the number of tumors, the degree of resection required, and the severity of underlying liver disease. When performing resection for patients with HCC, margins are obviously important for surgical planning for any pathology. And formerly, 1 centimeter margins were thought to be necessary. And 1 centimeter margins are what we shoot for, but they're not completely required. So here's a paper actually describing this. And they sought to evaluate the influence of the width and histological involvement of the resection margin on recurrence after resection for HCC. And they evaluated 288 patients who underwent hepatectomy for HCC and analyzed outcomes based on this resection margin. They found that recurrence rates were similar between the two groups who had margins that were under 1 centimeter or under 1 centimeter. So recurrence rates were exactly the same regardless. They did actually find high recurrence rates if the margin was histologically positive, so R1, or if there were satellite nodules found in the specimen, so an evidence of underlying parenchymal risk. Excuse me. Positive margins were associated with patients who had microvascular invasion, and recurrence occurred typically in the remaining liver, not only at the margin itself, and that's an indicator of the underlying field defect, if you will, within the liver parenchyma at risk. Previously, there was a report in 1993 of 480 patients from Japan who underwent resection for HCC over the decade of 1980 to 1990 that revealed the beneficial effect of anatomic resection in patients who did not have cirrhosis. And this is the data that really pushed for an anatomic portal oriented resection for patients who have HCC as compared to non-anatomic resection. And this is attributed to the predilection of HCC to um, kind of travel down the portal structures, and that's in keeping with its propensity for microvascular invasion. Further evaluating this is a paper from Regimbo, who compared outcomes for patients uh, with cirrhosis and small HCCs based on a limited resection versus this portal-oriented technique for resection that um, I described above. They looked at 64 patients who had Child's A cirrhosis, who underwent liver resection for small, and they defined small as under 4 centimeters HCCs over a more contemporary period as compared to the Japanese paper. And 34 of these patients underwent limited resection with a margin of at least 1 centimeter. And then the other cohort, 30 patients, underwent an anatomic resection, so a portal-oriented resection with complete removal of the portal segment, if you will. They found that 30-day mortality was exactly the same. Morbidity was the same as compared between the two groups. And the 5 and 8 years overall survival rates for limited versus anatomic resection were 35 versus 54%. So, and sorry, 6% versus 45% at 8 years. So essentially, a portal-oriented resection had a greater 5 and 8 year overall survival as compared to a limited resection. Local recurrence was actually more frequently observed after limited resection than after anatomic resection, and this is the paper that definitively drove the technique for portal-oriented resection for HCC. Again, just kind of rehashing this study from Regimbo, local recurrence is much higher for limited resection as compared to a portal-oriented resection, and corresponds with a higher 5-year overall survival. And then this next paper from an author that I can't even pronounce, Royer, in 2013, so a more contemporary study of 132 patients with HCC that are very small, so under 2 centimeters, so T1 tumors, and keep in mind that the prior paper was 4 centimeters and under. So T1 tumors 2 centimeters or under who underwent a non-anatomic resection had a much higher recurrence rate as compared to a portal-oriented resection. So again, driving home the point that an anatomic resection is key. Take-home points. Resection is preferred for patients with HCC and non-cirrhotic livers, and is applicable for select patients with mild cirrhosis. Um, this results in a 5-year overall survival of 35 to 50%. Prognostic factors for patients undergoing resection are obviously the underlying liver function, as well as tumor biology, such as size, vascular invasion, number of tumors, um, and AFP level. Having mild cirrhosis, we aim for a functional liver remnant of above 40%, As we discussed earlier, we can use PV safely, and we prefer a segmental or anatomic resection, a portal-oriented resection, over wedge resections when possible. So, what to do for a patient who has recurrent HCC following resection? The pattern of recurrence of this disease is often intrahepatic with new disease, not necessarily at the margin itself of resection, but in the remaining underlying liver parenchyma. And this reflects the patient's underlying hepatic disease. 30 to 70% of recurrence rate for patients with viral hepatitis C cirrhosis is observed. This is the ongoing inflammation within the liver. Vascular invasion and severe underlying liver fibrosis actually are the best predictors of worse overall survival and recurrence-free survival after resection and recurrence. And some patients with recurrence can actually be considered for repeat resection, and we'll talk about that here in a second. Median overall survival can be as high as 50 months in these patients as compared to 10 months for patients who have recurrence and aren't surgical candidates. So if you can, consider resection. And that's what's said in this paper from Japan by Dr. Kokudo in Annals of Surgery in 2003. They wanted to look at prognostic factors in patients who had a recurrence after curative resection for HCC to try and figure out what were the best criteria to select patients for resection. They looked at 334 patients who underwent a primary resection for HCC, and 67 patients out of those 334 underwent a second hepatectomy for recurrent disease. The overall 1, 3, and 5-year survival rates for the 334 patients were essentially 90, 75, and 55%. And in the 67 patients who underwent a second resection, they were 90, 70, and 55%. So essentially there was no difference in survival for these patients. They found that on multivariate analysis, absence of portal invasion, so microvascular invasion at the second resection, a single HCC tumor at their initial hepatectomy, and a disease-free interval of 1 year or more after their primary hepatectomy were the most prognostic factors after the second resection for survival. So basically a measure of their tumor biology and their disease-free interval really matters for prognostication following resection for recurrence. So they argue that repeat resection is the treatment of choice for patients who have undergone a primary resection, and we should consider these variables when considering for another operation. So a brief comment on liver transplant, and I say brief because again that could be another talk in itself, but liver transplant is the most definitive treatment for hepatocellular carcinoma, as well as the removal of the damaged liver parenchyma that leads to the ongoing inflammation and neoplasia. Initial experience for liver transplant for unresectable tumors unfortunately had high recurrence, but there was not great selection criteria, and therefore the data was muddy. But interestingly enough, liver transplant for patients who had liver failure, so not cancer, and then were found to have incidental hepatocellular carcinoma on explant, so therefore they were small and not seen, right? They actually had decent outcomes. So this suggested that better selection criteria was required to better stratify patients for liver transplant and organ allocation. Prior studies revealed that outcomes after liver transplantation for unresectable HCC was actually directly related to the stage of HCC. And this led to this landmark paper by Mazzaferro in a very well-known journal called the New England Journal of Medicine, actually delineating probably the most famous selection criteria scheme for patients to undergo liver transplant for HCC, and defined the Milan criteria. And the Milan criteria are for patients who have unresectable HCC tumors under 5 centimeters or having 3 tumors, so 3 tumors or less and none over 3 centimeters. So again, here's the Milan criteria, truly in the flesh. In this study, like I said, prior to the Milan criteria, 5-year overall survival after liver transplant for HCC was 30 to 40%. And in this study, they took 48 patients who had cirrhosis, and they indeed had small but unresectable HCCs and underwent liver transplant. And they underwent liver transplant if they met those Milan criteria that were previously described. 94% of these patients had cirrhosis related to hepatitis virus, either B or C. Mortality rate was 17%, and the actuarial survival rate after 4 years after liver transplant was 75%, and the rate of recurrence-free survival was 83%. The overall and recurrence-free survival at 4 years for the patients who met the predetermined Milan criteria were 85 and 92%, whereas the rate in the patients who didn't meet the criteria were 50 and 59%, so a much better survival with these selection criteria. And these patients' criteria were confirmed on analysis of the explanted liver. Here are the survival curves as I previously described for overall and recurrence-free survival for patients who did or did not meet the Milan criteria. So that established probably the best selection criteria for liver transplantation. However, some argued that this was too restrictive, and that's because this didn't have they felt that this did not have sufficient prognostic power to actually really discriminate for HCC recurrence after liver transplantation. And what they thought that this group thought that they didn't take into account were predictors of HCC recurrence, such as the greatest size of the tumor, the multifocality, as well as the presence or absence of microvascular invasion. In this group at UCSF, studied 70 patients who had cirrhosis over a 12-year period and underwent liver transplantation, and these patients had larger and more advanced stage patients. So in the Mazzaferro Milan study, no tumors had vascular invasion, and they were arguably small. The UCSF extended criteria show that solitary tumors under 6.5 centimeters or having 3 nodules with the largest at 4.5 centimeters or under, so bigger tumors, and then no tumor diameter total under 8 centimeters in this group had 90% and 75.2% 1 and 5 year survival after liver transplant, and 50% had a 1-year survival if they exceeded these limits. So if they went over these extended criteria, they did not do well. And so this is the UCSF extended criteria. So resection versus transplantation, they're, as I said previously, the two potentially curative surgical options. Advantages for liver resection is that there's no size criteria or no number criteria limited based on anatomy, and there's no necessarily vascular invasion restriction. You do preserve what liver function the patient has if you stratify your patients correct. The problem is there's recurrence, and it's frequent, almost certain, but it's difficult to predict how long and when it will occur. And the 5-year survival in the literature can be sometimes as low as 25%. Liver transplant for patients who have 3 or less nodules under 3% or 1 nodule 5 to 7 centimeters, the advantage is that it cures cirrhosis. It takes care of the tumor as well as cirrhosis. Recurrence is um, do happen, but albeit smaller as compared to recurrence for after resection. The problem with this is shortage of grafts, morbidity, uh, requirement of lifelong immunosuppression, and this results in a 5-year survival of around 70%. So take-home message: despite the absence of randomized studies, and there are none, there is evidence for a superiority of liver transplant in terms of long-term survival overall and recurrence-free survival. But as you know, there's a shortage of organs, so liver resection remains an important therapeutic option and one that occurs more frequently. With better selection and operative technique, we have reduced operative mortality, and you can have a 5-year survival rate upwards of 60 to 70%, so equivalent to liver transplant in select patients. Um, However, 10-year survival is 22% versus 50% after liver transplant. Here's an interesting paper that recently came out in 2018 talking about liver transplantation as an effective salvage therapy for patients with HCC who previously underwent resection or ablation. Here are the demographics of the two groups. PLT means primary liver transplant, so patients who underwent liver transplant as their initial therapy for HCC. And SLT means secondary liver transplant or salvage liver transplant in patients who underwent a transplant following prior resection or ablation. As you can see, the groups are pretty much well matched, other than the median MELD at the time of liver transplant. As expected, the MELD is higher in the patients who underwent a primary liver transplant, and that's probably because they had underlying liver dysfunction at the time of evaluation that precluded surgery. And in the matched cohort analysis between the two groups, looking at the cumulative risk of recurrence and then survival, the recurrence-free survival is the same in months after transplant for patients who underwent a primary liver transplant as compared to a salvage liver transplant. And similarly for survival following transplantation, the rates of survival for patients who underwent a salvage liver transplant are the same as compared to patients who underwent a primary liver transplant. So, sorry, go back. The authors conclude that salvage liver transplantation is an effective strategy for patients who have recurrent disease following a RFA or a previous resection for HCC. Couple slides on resection versus ablation, and the data has been mixed in the past. This is a randomized trial comparing RFA versus surgical resection for HCC for patients who conform to the Milan criteria, so the more strenuous criteria. This is 230 patients. They were deemed suitable for RFA or surgery for HCC, and they had regular follow-up. And as you can see, the patients here in the table are pretty much well matched in terms of clinical demographic data, except for the number of tumors in their size. So patients who had solitary tumors or had smaller tumors were more commonly in the resection group, and that makes sense intuitively, versus the RFA group, which had less patients who had solitary tumors. Looking at the 5-year overall survival on analysis in this trial, resection clearly had a much better overall survival at 76% at 5 years as compared to 55% for patients who underwent RFA. And the recurrence-free survival was much higher in the resection group as well at 51% at 5 years as compared to 29% for patients who underwent RFA. So bottom line is there's overall improved overall survival and recurrence-free survival for resection as compared to RFA. And this was also true in the subgroup analysis for solitary tumors that were small, tumors that were intermediate size between 3 and 5 centimeters, as well as multifocal tumors. Another study, resection versus RFA, though, for small tumors and single solitary tumors that were under 4 centimeters. In 158 patients, 55 patients underwent RFA, 93 underwent resection, and basically they found that they report here that recurrence-free survival and overall survival is similar between the two groups. So take-home message in terms of RFA versus surgery. RFA in patients who underwent transplantation and then they evaluated the explant of the liver. 80% of the tumor is necrotic for tumors that are under 2.5 centimeters, so small tumors. And the limitations on ablation are the size as well as the proximity to vascular structures. And that has to do with injuring or thrombosing vascular structures of interest as well as, and most importantly, a heat sink that basically takes the ability to effectively necrose tumor away. Ablation can be an effective strategy for extremely well-selected patients, but there's not a lot of data to support that at this point in time. And the consensus is really that RFA is not recommended for larger tumors and is best suited if a resection is not an option for patients who have tumors that are small, typically under 2 centimeters. Lastly, really quickly, a word about systemic therapy. Sorafenib is the drug a lot of people think about when they talk about systemic therapy for HCC, and this is the study that led to its approval in 2008. It was a multi-center phase 3, double-blinded, placebo-controlled, all the important stuff for a trial for this medication. And these were in Child-Pugh A patients with advanced HCC that were not candidates for surgery of any kind. They had undergone no previous systemic therapies. And basically found there was an improved median overall survival of 10.7 months for patients who underwent sorafenib as compared to 7.9 months for placebo. And they found that time to radiologic progression was longer for patients who underwent sorafenib of 5.5 months as compared to 2.8 months for patients who underwent placebo. This was the first large-scale randomized controlled trial that showed a survival benefit of any medical therapy for patients with advanced stage HCC. The problem is that this drug costs a lot of money at $5,400 per month, and there's a questionable role of this drug for patients with a poor performance status or with advanced stage cirrhosis. So local therapies for HCC, we're not going to talk about them here because that will just add to the length of this presentation, and perhaps it could be its own talk in the future. A disclaimer is the data presented was resection versus RFA, but now there's more advanced technologies for ablation, most recently with microwave ablation that is now available, and this is a completely different technology, and some argue that the data for RFA is not even on the same planet in terms of being able to be applied to microwave ablation. Obviously more prospective trials are needed. Other things not covered in this chapter that are important to talk about are Y90 radioembolization, immunotherapy for HCC, which we're starting more here at MD Anderson with Dr. Kassab, and some protocols we have now, chemotherapy, and minimally invasive surgical techniques for patients with liver dysfunction. So thank you, and I hope you enjoyed this and you learned something. I'm looking forward to